Hello, good evening. I'm really sorry not to be there. This is an automation project, so perhaps it's vaguely appropriate. My name is Dr. Sarah Defreitas. I'm a kidney doctor and general doctor as well, and I work in Barking, Havering and Redbridge University NHS Trust. I'm very pleased this evening to tell you a bit about a project that we did. This involved automating both the detection and also alerting of doctors to when a patient had acute kidney injury. So I'd like to start by telling you a little bit about why acute kidney injury matters. Many patients who suffer acute kidney injury when they become very unwell in hospital, and 10–15% of patients suffer with this. These patients are at much higher risk of dying, and they have 5 times the risk of needing to go to intensive care. And if they don't recover, even if they recover, they can have complications such as needing dialysis. So it's quite a severe problem. Earlier detection of acute kidney injury allows us to treat patients with acute kidney injury more aggressively and more appropriately, and this can help prevent progression of this problem. So we felt this was an important problem.
How is acute kidney injury diagnosed?
So acute kidney injury is diagnosed in 2 ways. You can look at how much urine someone's producing, but the other way you can figure out whether somebody's got acute kidney injury is by looking at a change in their blood results. And what we're looking for is a change from their baseline. So if you had a creatinine of 60 and it went up to 90, that would be the earliest stage of acute kidney injury, a 50% increase. The difficulty is that we don't always know someone's baseline. People certainly don't come into hospital with it written on a piece of paper. And there's a lot of variation between individuals. So for instance, I'm not very big, so I'm only 5'3", and I don't have huge muscle mass. So I don't have a very high creatinine. My creatinine is 60–65. There'll be someone sitting in the audience at your end, a tall man who works out in the gym 3 times a week, who's perfectly well, but has a creatinine of 100, and that would be normal for him. If my creatinine went up to 100 and I was ill, I would have acute kidney injury. And the risk is that people might not realise this because that blood test wouldn't look that abnormal, but it would be very abnormal for me. So the difficulty with diagnosing acute kidney injury is it's based on a change, and you need to really know what that person's baseline in order to figure that out is. We rely too much on normal range, and obviously normal range is an average. So my level gets lumped together with the tall gentleman with the creatinine 100, and say there's an average of 80. But actually 80 doesn't really apply to me. So it's about looking at a change, and that's the challenge. By programming automated alerts, what we've been able to do is get the computer to look back at people's blood results and figure out what their baseline is. The computer not only sets the baseline, but also looks for deviations from the baseline, and is actually able to not only detect the first stages of acute kidney injury, but any subsequent stages as the acute kidney injury might be getting worse. The alerts then appear next to the blood results, so they're very easy for the doctors to pick up. They see them with the results, and they're easy to interpret. They don't require training to read that off the screen. So it's been very useful in that way in terms of earlier recognition.
How did you establish these baselines?
We looked at how often people will have had bloods done before they came into hospital. And we were quite surprised. We found that most people have had blood tests done before they came in. So when we looked back, we looked at 3.6 million people who'd been admitted in the last 6 years. And we found just over half of them will have had a blood test in the last 6 months before they came in. And actually, if you go back a whole 12 months, then that goes up to 80%. So we found it was actually quite feasible to program the computer to look back at old blood results, find the baseline, and then detect changes from this.
How easy is the system for doctors to use and for hospitals to implement?
So as I said, our system is very easy because the alert actually appears next to the blood results. We also have a portal that updates every morning that the kidney specialist can interrogate, which is also very easy, user-friendly. Implementation-wise, this was extremely easy. We've actually got WIMPAC in our biochemistry lab, which is used by 40% of NHS trusts, and we did our programming directly onto that in just a couple of days. It didn't cost us anything. It was in-house. There are no ongoing costs, and given that this may be preventing people to progress to very severe acute kidney injury, it was a really worthwhile project.
Are there any other benefits?
I think conceptually this is an important project because we are moving away from thinking about the normal range that's based on a population analysis and actually looking more at what is normal for that patient. Programming that allows you to look at variation could also be used for other applications such as INR monitoring for people who are warfarin. So there are many potential applications for this going forwards. So if I can just sum up, we think acute kidney injury is a very important problem in our trust, and we have addressed the recognition of this by programming automated detection and alert system that helps the doctors pick up patients who have acute kidney injury earlier, and therefore these patients can be treated more aggressively and more appropriately. Many thanks.